Hey everybody, it's Dr. Wood, and today I want to talk about Chapter 4. We're going to understand drug dosing for special populations. So there's a lot of different variables that can affect how we dose our medications and the actions they have on people based off of potential gender, age, their weight, the dose that we administer. Genetics play a big role in a lot of cases, and other disease states the patient may have that will affect how well or not so well that our drugs work. So as far as age goes, it's important to note that we have different dosing based off of patients, whether they're infants, children, elderly, they're adults. And it's important to consider these factors here because their metabolism, their kinetics may change pretty drastically depending on how old they are. You tend to find that older patients tend to be a little bit more sensitive to medications, mainly due to the fact that their organs are starting to fail them, the kidneys are not working so well, the liver's working less well, and they really have the decreased ability to maintain that homeostasis. That's why you see so frequently that older patients, they have a hard time when they get standing up, they get dizzy. That's why falls are very common in that patient population. Medications can affect that pretty significantly. You also tend to find that infants are much more sensitive, mainly because of the immaturity of their organs. Maybe their kidneys are not functioning quite so well. Maybe their liver's not working so well, maybe because it's just not very mature. Especially the more preterm an infant is, the more likely they are to run into these problems here. So weight plays a big role as well. So imagine having patients who are either very thin, very obese, or maybe they're just a normal average weight there. The typical adult weighs around 150 pounds or so, but we know that people fall outside of that quite drastically. And again, you need to consider what to do when patients are outside of the normal range, right? So for instance, you may need to adjust doses up. If you have a heavier adult, sometimes you can only do that within certain reason, right? Sometimes you have to consider, well, if I have a patient who weighs 500 pounds, which can happen, they have a lot of adipose tissue, right? They have a lot of fat tissue there. And so depending on how the drug distributes in that tissue or doesn't, you may have to adjust the dose differently depending on the kind of drug you're dealing with. Patients who are very thin or may have very little body fat may need lower doses potentially. And so it really just depends on very much on a drug by drug basis there. One thing you can do to help try to account for the vast differences in weight is sometimes by dosing on body surface area. And so this is where you actually can dose based off the weight and the height of the patient. It's a little bit more complex in terms of how you calculate BSA. So it's pretty cumbersome, and the main place we do this most frequently is going to be with chemotherapy used for oncology purposes. So I do this all the time for pediatric patients with, say, leukemia, for instance. I will dose them based off their BSA and not just off their body weight, because again, it accounts for their height and their weight. Now, diet plays a big role in terms of drug dosing. For our patients, you're going to find that patients that have poor nutrition may have more likely experience adverse effects from medications there. For instance, if they're having starvation, you may find that they're more likely to develop certain side effects. Maybe they're dehydrated. Maybe drugs are going to have different distributions, all that sort of thing there. And so it can really affect not only the bioavailability, but also metabolism, the therapeutic effect. All can play a big role there. Sometimes you'll find diet can also interact with how well drugs get absorbed in the first place. So for instance, patients with Parkinson's, one of the big drugs that they take is one called levodopa. And if they're on a high protein diet, it actually can compete for binding with absorption with levodopa, and it can actually make their drugs work less well. So sometimes we'll tell patients, hey, take all your protein in the mornings, have your eggs with breakfast, and then the rest of the time don't have as much protein. That way your drugs get absorbed that much better. Gender plays less of a role than you might expect here. One thing to note is just the general body composition differences between men and women. Typically, you're going to find that women are going to have a slightly higher body fat percentage than males do. However, you're going to find plenty of people that go outside of this. You can find females that are bodybuilders that have a ton of muscle mass and have very low fat percentages. You can find men who have almost no muscle mass and a ton of fat. So it really just depends on the patient you're dealing with, but make sure you take that into account when you're looking at the weight of a patient. Actually go look at them, right? Don't just look at a weight and assume, okay, they must be overweight. Actually look at the patient and be like, wow, they're actually really muscular, right? That can make a difference in terms of how you're dosing some of the medications there. In terms of genetics, you may find that different genetic differences between patients can actually cause metabolism of drugs to differ, right? You may find some people are really good at metabolizing certain drugs and they may need higher doses to keep the same levels up. Or in some cases, it may be very slow metabolizers of a drug and they need much less of it in order to make sure that they don't get really high levels of the drug and cause toxicity there. Again, this is something we're going to see more of as time goes on and we get more access to cheaper genetic profiling for patients there, right? Certain diseases are going to impair body function. So, for instance, if I have a patient with chronic kidney disease, I know that's going to affect their renal function and may cause drugs to be cleared less efficiently. Sometimes I may need to adjust for that as well, right? And then also consider the mental state, right? Sometimes a positive mental attitude can help to cause a positive response for our medications. Sometimes you'll find the patient's mental state can have a really positive effect or negative effect on how they respond to a medication there, right? There certainly is a placebo effect where people think that, okay, well, if I'm doing something positive for my health, that, I must be getting better, and that can have some decent effects there. It can also go the other way as well. If a patient thinks that a drug's not going to work, then it may not work for them because they have such a negative stigma with it, and maybe their body is doing something to counteract that, right? So again, mental state can play a really big role here, which is why it's really good to educate and to help them kind of reason through it, so that way they kind of have some good buy-in, so that way they're really positive about taking that medication in the first place. Other variables that can affect how our drugs are going to work here is one going to be their history of previous medications, right? Sometimes when you have a lot of body buildup of some of these medications here, you can find that you can't just switch over from one drug to another because the body still is holding on to a lot of that. Sometimes what you have to do is, as one drug is leaving the body, you slowly taper up the dose of another drug to account for that. That prevents you from having too much drug of both of the drugs around, causing a lot of toxicity there. So it's something to consider depending on the half-life of the drug. Timing of administration can be important depending on whether something should be taken on an empty stomach. Some things need to be taken with food to increase absorption. That's going to be on a very case-by-case basis. And then also we just know that body functions change with the time of day, right? So for instance, if you have attention deficit hyperactivity disorder, ADHD, if you're taking amphetamines for that, like Adderall or Concerta, you don't want to take it near bedtime because you're going to be staying up all night because it causes so much overstimulation, right? So depending on when you need the effects of medications will determine when you might need to take them. The route of administration can play a big role in determining drug absorption. So for instance, if I take something orally, it has to go all the way through the GI tract and be absorbed from the small intestine before it actually gets into the circulation there. However, if I was to say apply a drug intranasally, there's a lot of blood vessels right there, and it can actually help to increase the absorptions much faster in those cases, right? Environment can play a big role. Obviously, the higher the altitude, less oxygen is available. Sometimes that can intensify the effects of certain CNS active drugs. Right, it can worsen dizziness. It can worsen the kind of the sleep-inducing sort of effects of certain medications there. So that's one thing to note. If you went from say Florida all the way up to Colorado, that can have big effects on how those drugs are causing them to work. Essentially, right. Heat and cold also play a big role as well. Obviously, when you're hot, you have dilation of blood vessels to try to dissipate that heat. Well, that can increase absorption of certain transdermal drugs, versus the cold may actually make it more difficult to absorb those drugs because when you're cold, you constrict the blood vessels, try to hold on to heat that much better. Other ways it can affect how people respond to drugs could be one, if they can't afford medications, right? So they don't have the money to get it, they don't have insurance, they're not going to take the medication, so the drugs just aren't going to work in those cases. That's why it's really important to determine what your patients can afford, what they can't afford. That's why you're making sure that when you're prescribing something, you want it to be something that is actually covered by the insurance that the patient has, or something that they can get maybe for free, depending on where they go fill it at, like Walmart or Publix and places like that. Sometimes have free or very cheap drug lists, and so it's a good thing to keep in the back of your mind before prescribing. Drug dependence can be a big deal, especially with certain controlled substances, things like opioids, things like amphetamines. And so people might be taking them outside of how you told them to take them because of the effects that they're trying to get from them, whether it be euphoric, whether it be in order to study harder for tests, whatever the case may be. This is important. It may kind of enhance the effects just because they're taking more of it. And then finally, patient compliance really just refers to how well they're taking it to the instructions that you gave them. Patients may be forgetful, or they may take it incorrectly because they don't understand the instructions. There's a lot of reasons for that. Education is really important with this, and helping them with things like pill reminders, or making sure they understand how they take the medication like they're supposed to, and different things like that. Now, when looking at pregnant patients or patients who are lactating, this is really important to consider whether a drug is actually able to cross the placenta and affect a fetus, or if it can cross into the breast milk for the infant to be exposed to. And so what you find is that the fetus tends to be at the greatest risk during the first trimester. This is mainly when a lot of organogenesis, or when the organs are initially forming, actually happens. The problem is when do women find out that they're pregnant? Well, it may not be till pretty far through the first trimester, depending on the case. So because of this, the fetus tends to be at pretty big risk. So if you have a patient who is maybe at risk for becoming pregnant, or you have someone who maybe on medications that could be potentially dangerous to the fetus there, making sure that they're using prophylaxis, things like that are all really important. And again, counseling is always what's going to go back to. Now, when something has negative effects on the fetus, that's called a teratogen, right? Or it causes teratogenesis in those fetus. We mentioned thalidomide before as being a teratogen. And again, we'll find that medications tend to be classified by the FDA according to their risk for causing teratogenicity or causing damage in those fetuses. And so what you find is that there are a significant number of births that can be affected by medications. Now, sometimes pregnant women need to be treated throughout the pregnancy because of weighing out the risk and the balances versus the benefits of the medications, right? If I have a mother who may be suicidal, if she's off of her antidepressants, well, then she may need to be on antidepressants through the pregnancy, which is how it is. And so we can't, we don't have a lot of good information about this in terms of studies because it's not really ethical to do studies in pregnant women. So sometimes it's difficult to tell what the right way to manage these patients is. And you'll find some drugs only require one-time exposure to be teratogenic, right? Depending on what trimester it is, depending on a lot of different factors. So the 5 different categories you're going to see in terms of pregnancy risk from the FDA are going to be A, B, C, D, and X. A being there's almost no harm whatsoever to the fetus. This is something like folic acid or vitamins, very, very low risk to the fetus. Nothing bad's going to happen to them. B, again, very safe to administer to a pregnant patient, very unlikely to cause any damage or risk to the fetus or to the mom there. Again, if my wife was pregnant, I would happily give her an A or B rated drug because we have good information to say that they're really safe in pregnant women. Next up, you get to category C. Now, category C is kind of like, I'm sure some of you might have this either at home or maybe at your parents' home, that drawer where kind of like everything just kind of gets shoved into, like old phones and random documents and things like that, kind of the junk drawer. Category C is kind of the junk drawer for drugs in terms of pregnancy. It's mainly for most drugs that we don't have any information on, which unfortunately is the lion's share of drugs. Meaning a lot of things get put into that category being like, well, we don't really know what it does to pregnant women. We don't really know what it does to the fetus potentially. And so because of that, you should be very hesitant to ever use a category C drug in a pregnant woman unless you have really good reasons to do so, right? The benefits severely outweigh the risk for that fetus. Category D is going to be something that we know definitely has harm to the fetus, but there may be rare instances where the risks to the baby are outweighed by the benefits to the mom. Very unlikely you're ever going to administer a Category D drug to a pregnant woman, but it could happen. And then finally, pregnancy Category X is proven fetal risk. There's absolutely no reason to ever use this. There's no case where the benefits to the mom would outweigh that risk. Okay, so A, B, C, D, and X. A and B being very safe, C being a big question mark, a big shrug. D and X definitely would avoid if ever possible, especially Category X. Now, looking at medication use in children, it's really important to understand that kids are not just miniature adults. They are physiologically extremely different depending on their age. If you look at someone who is 6 months old versus 6 years old versus 16 years old, they're very, very different in terms of their physiology. Their metabolism, their excretion may be very different to one another. And so it may be very difficult to find good dosages for medications for kids, mainly because it's hard to do studies in them, right? They have the same issue of being a very, protected group in terms of ethics as pregnant women, right? It's very hard to do studies in these kids. So a lot of times we take data from adults and try to extrapolate it back to those children, and it doesn't always correlate one-to-one, which is really difficult. The biggest things to do, though, is to make sure that you're dosing based off of either their body weight, or if you want to, you can account for their height and then use their body surface area. You find some drugs are going to be dosed based off of age. This is pretty unreliable. The main reason being is that when you say, okay, well, a 5-year-old's going to get this much. Well, childhood obesity is a big problem. So you can have a 5-year-old that weighs as much as an 8 or 9-year-old, and there may not be enough medication to them. Or they could have a chronic illness to where they weigh as much as a 3-year-old, and maybe is too much medication for them. So really, you always want to make sure you're dosing at least off of body weight, if not use body surface area. And again, for our chemotherapy, for our oncology patients, that's all we do is just body surface area dosing. Most everyone else in pediatrics is going to get body weight dosing. And again, depending on their weight, depending on their metabolic rates, their organs, you may find they tend to be more sensitive to the medications on an individual basis. But again, height and weight are super, super important, especially when you think about working in the ER. You'd have say an 8-month-old who shows up, who's in cardiac arrest, and you ask the parents, how much does the kid weigh? And they may not know. They may only say, well, the weight at the 6-month visit was this, and that could be totally different now. And so this is really important to make sure you have accurate heights and weights anytime you go visit a health professional. And make sure that you keep that documented, so that way if your kid does need treatment, you know exactly how much the kid weighs. Now, looking at older patients, you tend to find that as people get older, their organ function is going to go down, their dentition gets worse, and they have an increased risk for overdose potentially. Not only that, but they tend to be on a lot of medications, right? They undergo polypharmacy, where they're on many medications for their multitude of disease states. And that means they're going to be more likely to, one, not be compliant with their regimens. Either they're forgetful, or the regimen is very complicated, or they can't afford it, or they may just not understand the instructions. And not only that, but a lot of the medications can interact with one another, and that can lead them to some very severe toxicity. Also, think about it. They're seeing an orthopedic doc for their arthritis. They're seeing a cardiologist for their AFib. They're seeing a pulmonologist for their COPD. A lot of times they're not all communicating with one another, and so it can be very difficult to get a full medication list because most docs don't know what the other docs are prescribing, and there may be some interactions there that no one knows about. Now, as I mentioned, not only do you have to worry about the legend drugs that older patients are taking, but also they can grab whatever OTC meds they want. And so you really have to ask about it. Not just ask what medications you take that you get with a prescription, but what do you take without a prescription? What herbal supplements do you take? What vitamins are you taking? Because you may find that they may be taking more than one drug that fits in the same class. You may find that they're taking medications to treat side effects caused by other medications. You may find there's significant drug-drug interactions. Or ways to get around this would be when the patient's given a very low effective dose for one drug and then it's not really working for them, so they end up taking another drug to try to supplement that. And again, using two drugs when one's going to do is never a good thing, right? Fewer drugs is generally better for the majority of these patients here. So some things you can ask, these are just general questions when you're doing a history on a patient. You should ask about, say, okay, well, what vitamins, supplements, over-the-counter drugs do you take? How do you describe your ability to read the medication label? Sometimes the print's really small and they may not be able to read it, depending on the case there, right? Tell them to tell you how they take their medications. Don't just say, hey, do you take your medications like you're supposed to? Because of course they're going to say yes. But ask about, how do you take your medications? Have them teach back to you in order to identify any errors they may have about their medication regimen, right? And again, a lot of different issues that may result from polypharmacy. They can develop arrhythmias. They can have disturbances in balance, which means they're more likely to fall. And when old people fall, they tend to break hips. They break their femurs. This can lead to significant morbidity. It can lead to mental status changes, constipation, hypertension. A lot of factors here that can lead to significant polypharmacy and lead to significant outcomes from that. So you always want to remember, fewer drugs is better. And so if you're the primary care person, if you're that one central person that is, kind of managing that patient, make sure you get all that information from all the specialists. That way you get a full medication list to make sure they're not taking anything that could be really harming them. So other things to consider: simplify the instructions, be very clear, concise with your dosing on how to tell them to take their medication. Encourage them to read all the labels, or at least give them information that's very based on their education level. Because you may find patients may not have all that great of reading apprehension, right? They may not be above an elementary school level, depending on the case, okay? Make sure you're listing all the medications, including the strength, the dose, length of time they're being taken there, and they take that list to each physician's visit. If they go to the ER, they should take that list with them to make sure that they are going to have a full accounting for all those drugs there, okay? Because a lot of times they don't have that list. Older patients are like, yeah, I think I take something for my blood pressure, but then they don't remember what it is or what dose it is, and it's not really all that useful there, okay? And sometimes you can actually give samples to help out with compliance for patients who can't afford drugs, but just remember, samples might not be a great long-term solution because they may find they don't have access to that for the long term. So just something to consider. As I mentioned, be aware of the education level of the patient. Sometimes if they're illiterate, they may be really embarrassed to ask for help. And so you may want to try to double check with them, just say, hey, what does that label say? And that way you can kind of uncover that and help them out with finding a way to take the medication appropriately. And again, sometimes they may not even realize that two drugs may be the same thing. For instance, I have patients who have heart disease and they know they have to take a baby aspirin every day for that. But also, they end up taking a product called BC powders. I should say BC, not BD. They take these BC powders that also happens to contain aspirin. I actually had one patient who every time he had chest pain, he would take a BC powder for it, but he didn't know it had aspirin in it. And so basically, this guy was taking, every time he had chest pain throughout the day, multiple times a day, he'd take a BC powder. And then when EMS arrived one time, he called 911 because the chest pain wasn't going away. 911 came up and they said, "Hey, have you taken any aspirin today?" And the guy said, "No, I haven't taken any aspirin at all." He didn't know the BC powder contained it. So EMS, they went ahead and gave him some aspirin, like they're supposed to, right? Then the patient got to the ER, and I guess the patient didn't realize he had received aspirin from EMS. And so the doc says, "Hey, have you taken any aspirin today?" And the guy says, "Nope." So he gets another aspirin dose. So not only was he having a myocardial infarction, but now he had an aspirin overdose on top of that we had to deal with. So it can be really dangerous. So make sure they're aware of things that interact with one another, things that, over-the-counter products that contain significant drugs in them. They need to know about that. Again, synergy can be really important here. If the patient was being told to take aspirin for their heart disease, but then they're also on a blood thinner, that can lead to more bleeding. Could be a big risk there. So always make sure you address any questions a patient has, and make sure they feel like they are able to talk to you openly to ask those questions. Because if they feel like you're kind of coming down on them sort of as a judgmental type of person, then they may not be as likely to open up to you. But make sure you have a nice, open, curious environment, and they're more likely to ask you those questions and make sure everything's answered before they leave the office. So cultural differences can play a big role in how people regard their illness, So depending on kind of what their cultural heritages are, they may have folk remedies or folk medicines they're using that may interfere with prescription medications there. People may not believe in taking prescription medications depending on their culture there. And oftentimes communication can be a really big problem here. So it's important that you have translation services that are available. Again, being here in Orlando, we have a big travel hub. So we have patients coming in from all over the world to come to Disney. And then we get sick, they come and see us, right? So I have people from South America, I have people coming from Europe, I have people coming from everywhere. And it's important that we have translation services available to try to allow us to communicate with them better. But also think about, other things like religious beliefs. Certain religious beliefs will prevent certain medications from being used, right? I can't give blood products to someone who's a Jehovah's Witness, so I have to find other ways that they're at risk for anemia in order to manage that, right? So again, you have to take all these things into account and be a partner with your patient, and don't just say, "Well, that's silly. That's a silly cultural belief. I don't really care about that. Let's go ahead and use this treatment anyway." You have to make sure approaching them with the same respect you would anyone else, and make sure you try to honor these whenever possible. And again, this slide here kind of reiterates what I was already saying there, but just understand that diversity is present. Wherever you end up practicing, be aware of the area that you're working in, be aware of the people that live there. For instance, where I work, there's a very large Hispanic population, and so they have certain beliefs about healthcare, right? That may be different than, say, where I came from. If you work somewhere else, you may find there's different populations there. You need to be cognizant of that. You need to be open to that, right? Be aware of the language barriers. Be aware of the beliefs they have about medical care or about home and folk remedies, and make sure you approach them with respect and dignity, because again, they need to be a partner with you on their health care and not an adversary. Okay, so it's really, really important to consider all these different beliefs. This slide's important about using both verbal and nonverbal communication skills here. This is really important when you're interacting with a patient to make sure that you're kind of engaging them and using good nonverbal communication. Make sure you're looking them in the eye. Make sure you're using kind of good open body stance, because otherwise if they feel like you're too busy, or if they feel like you're not paying attention to them, they can tend to shut down, right? It can lead this to this environment of disrespect. And so just be aware of that. Be aware of how you're being perceived by the patients, and be aware of the fact that when you're seeing a patient in the ER or anywhere, they may be having the worst day of their life, and you need to be aware of that. You need to be sensitive to that, and make sure that you're approaching every patient with a lot of empathy, and that can help go a really long way for patients to feel comfortable, and they feel like they can trust you, and they feel that they're really going to be taking good care of them. So that's it for this section. If you have any questions, please let me know, and I'll talk to you soon. Thanks a lot. Bye.